Welcome to this Step 2 clinical knowledge review on congenital heart disease test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for congenital heart disease and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the pediatrics and cardiology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for congenital heart disease. Second, we will apply specific strategies for questions about cyanotic versus acyanotic lesions, murmur identification, and next best step management. And third, we will master the next best step question format for diagnosing and managing congenital heart defects. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the cyanotic versus acyanotic split. When you see a question about a pediatric heart problem, immediately ask yourself, is this child cyanotic or acyanotic? For cyanotic lesions, the key question is whether the cyanosis improves with supplemental oxygen. If it does not, you are dealing with a cardiac shunt. Tetralogy of Fallot presents with hypercyanotic episodes called TET spells that classically improve with squatting or knee-to-chest positioning. Transposition of the Great Arteries presents with severe cyanosis on the very first day of life, and the chest X-ray shows an egg-on-a-string silhouette. Truncus arteriosus and total anomalous pulmonary venous return also cause early cyanosis. For acyanotic lesions, think about left-to-right shunts that may initially be asymptomatic. Ventricular septal defect is the most common congenital heart defect overall. Atrial septal defect gives you a fixed split-second heart sound, which is a classic board buzzword. Patent Ductus Arteriosus presents with a continuous machine-like murmur. Coarctation of the aorta shows upper extremity hypertension with weak or absent femoral pulses. This cyanotic versus acyanotic framework should be your first mental checkpoint on every pediatric cardiology question. Strategy 2 is all about recognizing heart murmurs in children, because the boards test this in so many different ways. For innocent murmurs, remember that they are soft, systolic, and change with position. The most common innocent murmur is a still murmur, which is a low-pitched vibratory murmur heard at the left lower sternal border in young children. Innocent murmurs have no associated symptoms, no diastolic component, and no thrill. The child is otherwise healthy and growing normally. For pathologic murmurs, look for murmurs that are harsh, holosystolic, or diastolic. Associated symptoms are your red flags: failure to thrive, diaphoresis with feeding, hepatomegaly, or cyanosis all point to a pathologic cause. A loud holosystolic murmur at the left lower sternal border suggests ventricular septal defect. A fixed split-second heart sound suggests atrial septal defect. Remember, any diastolic murmur is considered pathologic until proven otherwise. These murmur characteristics are classic board differentiators. Now let us go through high-yield stem recognition. For Tetralogy of Fallot, the classic stem is an infant with cyanotic spells that improve with squatting or knee-to-chest positioning. The chest X-ray shows a boot-shaped heart. The echocardiogram reveals the 4 classic features: right ventricular outflow tract obstruction, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. For transposition of the Great Arteries, look for a newborn with severe cyanosis within hours of birth that does not improve with supplemental oxygen. The chest X-ray shows an egg-on-a-string silhouette. This is a surgical emergency requiring prostaglandin infusion to keep the ductus arteriosus open and maintain mixing of blood. For ventricular septal defect, the classic presentation is an asymptomatic infant with a harsh holosystolic murmur at the left lower sternal border. Small defects are often louder than large ones, which is a favorite board trick. Large defects may present with heart failure symptoms including poor feeding and tachypnea. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A newborn male delivered at 39 weeks develops severe cyanosis within the first few hours of life. Supplemental oxygen does not improve his oxygen saturation. On physical examination, there is a single, loud second heart sound. A chest X-ray shows a narrow mediastinum with an egg-shaped cardiac silhouette. What is the most appropriate initial step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Newborn with severe cyanosis that does not respond to supplemental oxygen, a single loud second heart sound, and the classic egg-on-a-string chest X-ray appearance. That combination is transposition of the great arteries until proven otherwise. Step 2. Apply the rule. The board rule you must memorize is, when you see cyanosis that does not improve with supplemental oxygen in a newborn, think ductal-dependent cardiac lesion. The very first step is always prostaglandin E1 infusion to keep the ductus arteriosus patent and maintain blood mixing between the two parallel circulations. Step 3. Eliminate wrong answers. Emergent surgical repair is the definitive treatment with the arterial switch operation, but it is not the initial step. Supplemental oxygen has already been tried and failed, which is the hallmark of a cardiac shunt lesion. Furosemide treats heart failure, not cyanotic heart disease. The correct answer is B, prostaglandin E1 infusion. Here is our second practice question. A 4-month-old infant is brought in for poor weight gain and diaphoresis during feeding. On examination, the infant is tachypneic with subcostal retractions. A harsh holosystolic murmur is heard best at the left lower sternal border. A chest X-ray shows cardiomegaly with increased pulmonary vascular markings. What is the most likely diagnosis? Think through this one carefully. The key findings are heart failure symptoms in an infant combined with a specific murmur location. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes heart failure in an infant, poor weight gain, diaphoresis with feeds, tachypnea, and retractions. The harsh holosystolic murmur at the left lower sternal border is the classic location and character for a ventricular septal defect. The chest X-ray showing cardiomegaly with increased pulmonary vascular markings confirms a left-to-right shunt causing volume overload. Now, why is ventricular septal defect the answer? Atrial septal defect produces a systolic ejection murmur with a fixed split-second heart sound, not a hollow systolic murmur. Patent Ductus Arteriosus produces a continuous machine-like murmur, not a hollow systolic one. Tetralogy of Fallot would present with cyanosis and decreased pulmonary blood flow on chest X-ray, not increased pulmonary markings. The correct answer is C, ventricular septal defect. Let us review congenital heart disease management for the boards, because this comes up constantly. For acyanotic lesions, remember that small ventricular septal defects often close on their own and just need observation. Large defects causing heart failure are managed initially with diuretics like furosemide and caloric supplementation, followed by surgical repair when the child is stable. Atrial septal defects are monitored if small, but significant ones require repair, often with a catheter-based closure device. Patent ductus arteriosus in premature infants is treated pharmacologically with indomethacin or ibuprofen, which inhibit prostaglandin synthesis and promote closure. Coarctation of the aorta requires surgical repair or balloon angioplasty. For cyanotic lesions, the key management concept is prostaglandin E1. Transposition of the Great Arteries requires immediate prostaglandin E1 infusion, followed by the arterial switch operation, usually within the first 2 weeks of life. Tetralogy of Fallot is managed acutely with knee-to-chest positioning during TET spells, and definitive repair involves patching the ventricular septal defect and relieving right ventricular outflow tract obstruction. Boards absolutely love asking about prostaglandin E1 as the initial step for any ductal-dependent lesion. Memorize that concept. Here is our third practice question. A 6-year-old boy is found to have an asymptomatic heart murmur during a routine physical examination. The murmur is a grade 2 out of 6, low-pitched, vibratory systolic murmur heard best at the left lower sternal border. It decreases in intensity when the child sits up. The child is active, growing well, and has no other symptoms. What is the most appropriate next step? This is a classic murmur identification question. Think about what features distinguish an innocent murmur from a pathologic one. We will walk through it next. Let us break down this answer. The classic pattern here is a grade 2 out of 6, vibratory systolic murmur at the left lower sternal border in an active, well-growing child. The murmur changes with position, decreasing when the child sits up. This is the textbook description of a still murmur, the most common innocent murmur in children. No further workup is needed. Now the key distinction. An echocardiogram is unnecessary for a classic innocent murmur in an otherwise asymptomatic child. Ordering imaging here would be an overreaction and is a common wrong answer choice. Immediate cardiology referral is reserved for concerning findings like diastolic murmurs, loud, harsh murmurs, cyanosis, or symptoms of heart failure. A chest X-ray and electrocardiogram are also unnecessary when the clinical picture clearly fits an innocent murmur. The correct answer is C. Reassure the family that this is a normal finding. Here is a critical test-taking pearl about the prostaglandin E1 rule. Any newborn with cyanosis that does not improve with supplemental oxygen should receive prostaglandin E1 immediately. This applies to transposition of the Great Arteries, critical pulmonary stenosis, tricuspid atresia, and other ductal-dependent lesions. The ductus arteriosus must stay open to allow blood mixing or pulmonary blood flow until surgical intervention is possible. The boards frequently test whether you know to start prostaglandin E1 before ordering imaging or consulting surgery. It is always the first step. Know the major side effect of prostaglandin E1, which is apnea, so these infants need to be monitored closely. Also know that indomethacin does the exact opposite and closes the patent ductus arteriosus. This prostaglandin concept, where E1 opens and indomethacin closes, is one of the highest yield topics in pediatric cardiology for Step 2. Commit it to memory. That wraps up our review of congenital heart disease test-taking strategies for Step 2 clinical knowledge. Remember to review the Pediatrics and Cardiology chapters in First Aid and your question bank. Focus on the cyanotic versus acyanotic classification, murmur identification, and the management algorithms we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.